Good day and welcome back to Occupational Medicine Pearls podcast. My name is Yi and I'm your host for the show today. I'm going to tackle one of the most important topic in the occupational medicine, that is contact dermatitis. It is a big topic and I will try to cover as much as I can in a single episode. Occupational skin diseases account for a significant proportion of workers' compensation claims in Australia, and contact dermatitis is by far and away most frequent diagnosis. It affects workers across a huge range of industries, including healthcare, hairdressing, construction, manufacturing, food processing, and cleaning, and the list goes on. Thanks to the improving control of the hazard exposure, the number of cases are declining over the time compared to a few decades ago. But we still have a lot to go on before we can say that this is all under control. Let's start the episode. By definition, contact dermatitis is an inflammatory skin condition resulting from direct contact with an exogenous substance. There are two major types that we need to distinguish because pathophysiology, prognosis, and management are quite different. As you can guess, the first one is irritant contact dermatitis, or ICD. This is a non-immunological reaction and due to direct cytotoxic effects on the skin from a substance. No prior sensitization is required, and anyone exposed to a sufficient concentration for a sufficient duration can develop that. It accounts for roughly 70 to 80% of all occupational contact dermatitis. It can be acute from a single strong exposure, like a chemical splash with a strong acid or alkali, or cumulative, which is far more common in occupational setting. Cumulative ICD results from repeated low-grade exposures that progressively damage the skin barrier. Think of at wet work, healthcare workers who wash their hands 40 times a shift, or the hairdresser in constant contact with water or shampoo. Clinically, you will see erythema, dryness, fissuring and scaling, and typically well demarcated to the area of contact. In the acute chemical burn scenario, you can see vesicle and even necrosis. Another type of contact dermatitis is allergic contact dermatitis. It is a type 4 delayed hypersensitivity reaction and a cell-mediated immune response. It requires two phases as any immunological reaction. Initial sensitization phase, which is clinically silent usually, followed by an elicitation phase on re-exposure where clinical dermatitis appear, typically from 24 to 72 hours after contact. The clinical point here is once sensitized, the worker is sensitized for life. Even very small amounts of the allergen can trigger a reaction, and the dermatitis can extend beyond the area of direct contact. You might see a more diffuse spreading skin pattern. ACD accounts for around 20% of occupational dermatitis, but it tends to carry a worse prognosis because avoidance of the allergen must be absolute. They are not the only type of contact dermatitis or skin problem that we see. Other skin issues that we can see in occupational setting can include contact urticaria through type 1 IgE-mediated immediate hypersensitivity reaction, and they can be due to natural rubber latex, or protein contact dermatitis, and they are due to hybrid reaction to proteins. Common triggers include animal or fish proteins and commonly seen in food handlers. Another type is phototoxic or photoallergic dermatitis, and usually due to UV light exposure. And it can also be due to topical agents that people apply on the skin as well. After looking at the major classification, let's look into common causes. For irritant contact dermatitis, the main risk factor in occupational setting is wet work. Safe Work Australia defines significant wet work as hands being wet for more than 2 hours per shift, or frequent hand washing exceeding 20 times per shift, or prolonged occlusive glove wear for more than 2 hours. So there are 3 criteria, but you do not need to meet all 3 criteria. Any one of them could. Other common irritants can include soaps and detergents, solvents, oils, metal working fluid, mint, and its alkaline constituents, and any acid or alkali in the manufacturing that has caustic or corrosive effects. On the other hand, for the allergic contact dermatitis, causes include chromium, classically from cement. It is still an issue despite the push towards low chromium cement in Europe, nickel from tools and metal alloys, epoxy resins, widely used in construction, composites, and coatings, and they are potent sensitizer. Common epoxy resins include bisphenol A, bisphenol F, and other Novolac epoxy resins. And I need to pronounce his name correctly. It is methyl methacrylate. They are common epoxy resins that we may encounter in the workplaces. Rubber accelerators such as diurems, carbamates, and marcato-benzothiazoles, particularly from the protective gloves, hair dye, specifically paraphenylene diamine or PPD, and hairdressing, preservative like methyl isothiazolinone and formaldehyde releases in industrial products. MI is even in the shampoos as well, and colophony, which turns up in soldering flux and adhesives. In A-Form Stage P exam, potential scenarios are that there is a worker who works as a hairdresser, food handler, construction industry, healthcare worker, and we may need to look at potential sources of allergic contact dermatitis. So this is about causes, and then let's go into how do we diagnose them. Diagnosis is predominantly clinical. Without knowing the clinical context and exposure history, we can't get to the different testing. So it requires a systematic approach, and you may best to print out a template, print it out, and ask people, going one by one line of their exposure. There are occupational history aspect, and there is also non-occupational history aspect. In the occupational history, we need to check what tasks they perform, substances they handle, duration and frequency of contact, and also when PPE are used, how long do they use them, what type, and the effectiveness of the usage. You want a temporal relationship to prove any causal link between the exposure and the outcome. Did the rash start after beginning a new job, a new task, or using a new product? Does it improve when they are away from the workplace? That cannot happen over a few hours, so we need to ask weekends, holidays, or periods away from work. That temporary improvement away from exposure is one of the strongest clinical clues. The other factor is, have they handled similar chemicals in previous jobs, and how did they react to it? From non-occupational exposure, that covers a lot. So we have to start from look at individually what sort of cleaning product, hair product, cosmetic product you use, what do you eat, and what sort of materials do you use at home, and hobbies. What sort of hobbies do you have? Do you expose to paint, metal, animal products during your personal life activities? That's important. And if they have any other history of atopic background, we need to get detailed history about eczema, hay fever, or asthma conditions. Because of atopic, individuals have a compromised skin barrier. Not all the time, but they may have them, and they are higher risk of ICD in particular. On the clinical examination, we need to look at distribution and morphology carefully. Hands are the most commonly affected site in occupational dermatitis. For ICDs, the pattern is typically well demarcated to the area of contact. On the other hand, ACD may show initial dermatitis at the contact site, but then spread more diffusely, and we need to document the presence or absence of secondary infections or lichenification from chronicity, and if there is any other new changes to suggest any secondary diagnosis. After taking history and physical examination, the doctor would have some idea on whether this is a clear case of irritant contact dermatitis, which you could be right in, 80% of the time, versus allergic contact dermatitis. If you know this is irritant, you do not need to do any further investigation. However, if you are not sure, or if you have suspicion about allergic contact dermatitis, we need to proceed with investigation, which is patch testing. It is a gold standard investigation for distinguishing ACD from ICD. Patch testing checks for type 4 delayed hypersensitivity reaction. It is not a screening test and not predictive of future sensitization. Conditions or situation we need to consider to do patch tests include if there is the suspicion for allergic contact dermatitis and there is dermatitis persisting despite irritant avoidance. There is involvement in facial, eyelid, flexural, and airborne pattern dermatitis. And when the diagnosis affects compensation, job modification, or regulatory obligations. However, it is not indicated when there is acute widespread dermatitis or active dermatitis on the testing site, which is usually on the back, pure irritant contact dermatitis, urticaria, or protein contact dermatitis. If the worker has severe immunosuppression, likely to suppress response, or if this is pre-employment or pre-placement screening, and then we are not going to do that. In Australia, the standard series used is typically the Australian baseline series, which is updated periodically. It is also important to test workers' own workplace substances when possible, so-called own product testing. And as an occupational doctor, we need to liaise with the dermatologist about any other relevant additional series based on their occupation. For instance, hairdresser series, plastic and the glue series, or the rubber series. Patch testing involves applying allergens to the back and the occlusion for 48 hours. Occlusion means putting a diluted version of allergen on the skin and apply with the tape, and that stays on duration of the period, and the person cannot shower until the test result is available. It is kind to provide a medical certificate to the worker during that time because you would be relatively feeling itchy on your back and not comfortable, so your sleep is not good and during that time, and you can't shower. Who want to go out when you can't shower? So the first reading is done at 48 hours. So you remove the tape at that time, and second reading is performed at 72 or to 96 hours. So usually 3 appointments are needed, and then we can get the next week reading if there is any suspicion of delay process. The first follow appointment seen at 48 hours is just to see if there is reaction. If you do not see any reaction, it is not conclusive. We still need to wait until 96 hours is finished before making any interpretation. If there is a strong reaction from the first time, then it is conclusive. Although it is gold standard, from the sensitivity point of view, there is moderate sensitivity. What it is, specificity could be higher when true allergic reaction present. Sensitivity can be limited by incomplete allergen panel, round allergen tested, low allergen concentration, and detected or unknown immunosuppression. So we need to know these factors when we are requesting a test. We can get true positive, which then that it might be useful for management, but it can also be false negative situations. So as I mentioned, if relevant allergens are not included in the test panel, which is the most common reason, inadequate allergen concentration, immunosuppressive medication, or testing during disease remission, poor technique or poor occlusion of the tester. When you have a strong suspicion of allergic contact dermatitis and the test result is negative, we will need to reevaluate of exposure history, and they require testing of other additional materials because the negative test does not exclude occupational causation. A key point is it is important not to use the result of the test alone to deny workers' compensation claims. On the other hand, false positive results may happen due to irritant reaction, and there is excessive high allergy concentration being used, angry back syndrome where skin react from a nearby reaction, the whole back is reacted, not due to the actual content, or if their testings are performed on the inflamed or reactive skin area. So when false positive results that you are seeing, you need to revisit the causal pathway and to consider whether it makes sense or not. Diagnosis is not going to be complete without understanding the workplace, Therefore, we should be performing worksite visit, looking at the exposure pathway controls, safety data sheet of the chemicals or products in use, and it is important to know what type of PPE are used and their compliance, and also PPE itself be the source of allergy as well. After this, we will go to management. How do we manage that? So the same with any other occupational condition, we will need to follow through hierarchy of controls. Starting with at the top of the hierarchy is elimination. Can offending agent be eliminated or substituted? For example, switching from a chromium-containing cement to low chromium alternative, or replacing a sensitizing epoxy with a less sensitizing formulation. We had removed latex glove in many of the food handlers' positions and in many healthcare industry as well for the whole reason, because it can be done and it is dangerous otherwise. In practice, substitution may also be technically difficult in some industries, but it should always be considered a recommended one feasible. For engineering and administrative control, it may include automation to reduce direct skin contact, use of enclosed system, and local exhaust ventilation to reduce airborne exposure to volatiles. And if there are administrative control, we are thinking job rotation to reduce cumulative exposure time, scheduling wet work tasks to allow adequate recovery period for the skin, and ensuring adequate washing and drying facility available. When the controls are not adequately implemented, cross-contamination could happen in different work areas, so we need to have that in mind when you are performing worksite visit. After the administrative control, we go to personal protective equipment, PPE. It is the front line in the practice, but it is at the bottom of the hierarchy for a reason. Glove selection must be appropriate to the substance we are trying to protect. It has to be the correct material, correct breakthrough time, and as I mentioned earlier, the glove itself can be the problem. If someone has a rubber chemical allergy, you need to switch to accelerator-free glove. Nitrile gloves have largely replaced latex in many work settings, but diuretic allergy can still be an issue with some nitrile products. So it is important to read the SDS of the glove material before you are buying from the distributor. One other way of protecting your skin is using thin cotton liner under the glove. That can be useful to reduce maceration and contact with the chemical. Moreover, it is better for wet work as well. These days, emollient and barrier creams are available at washing stations in most hospitals. Pre-work barrier cream can reduce irritant penetration, and regular emollient use help restore and maintain the skin barrier. Soap-free cleansers should be replacing harsh soaps, and they are simple and they are effective. Just need to be organized enough to put them in the right place in the workplaces. We can also recommend medical treatment. One thing I need to stress is that as an occupational doctors or physicians, we are not the treating doctor. So we can recommend treatment, but it is the treating doctor's role to manage if there is an active occupational dermatitis. If there is acute flare-up, topical corticosteroids are the mainstay. Usually betamethasone dipropionate or mometasone furoate are quite useful. You can apply for anywhere including your face for short term, but predominantly it is useful for the hands. For severe, extensive or refractory disease, oral corticosteroids such as prednisolone are useful. And if there are secondary bacterial infection, we need to identify them and treat with appropriate antibiotics. Usually oral antibiotics are better than topical in this situation. If it is ACD, the main thing is avoidance of the identified allergen. If you have a few suspicion, you need to consider whether you can allow the worker to work while avoiding these suspicions until the patch test result is available. Other things we need to explain is if it is ACD, due to the nature of the immune reaction, antihistamines are not effective. The standard or the routine for the skincare between the attacks is also important advice. So you can print out health information leaflet about general skincare for all the workers in the high-risk industry, and they can use them as to protect themselves daily. So I finished the clinical aspects, diagnosis, and management of the condition. And then let's move to what we do, fitness for work assessment, because that's what's the most important, isn't it? Fitness for work assessment in contact dermatitis is not a binary decision, and it is rarely a simple fit or unfit. Similar to other medical conditions that we determine, you are almost working in the space of fit with restrictions or fit with modifications. Your assessment needs to consider three things. First, clinical severity. Is the dermatitis currently active and impairing function, or it is quiescent? Second, the specific diagnosis. Is it ACD or ICD? And to what substance? This has major implication for what workplace modification needed. Third, the workplace itself. Can exposure actually be controlled to a degree that allows safe return? If we start with these three considerations, we will cover all the required grounds. For ICD, job prognosis is generally better because we are dealing with a dose-response relationship. If we can reduce the exposure below the threshold for irritation, the worker can often return successfully. This might mean modify duties to reduce wet work hours, improve glove controls, emollient regimens, and job rotations. We should and also ensure that dermatitis has settled to a reasonable degree before returning. Returning with actively inflamed fissure skin is setting up the worker for failure. It's not very helpful to them as well. And because of their barrier is already compromised, even if they're improving, there is higher chance of recurrence. For ACD, it is quite challenging since sensitization is permanent and even very minute exposure can trigger elucidation. The worker may not be able to return to the same task involving the causative allergen at all. If the allergen is present in a specific product and a substitute product is available that doesn't contain that allergen, returning to the same role may be possible. But if the allergen is ubiquitous in that work environment, say chromium for a cement worker or epoxy for a composite laminator, redeployment or rehabilitation to a different role within the same employer, or in some cases, retraining for a different occupation may need to be considered. This is a challenging conversation any doctor need to have with the worker and the workplace when we have exhausted all the options. Sometimes we rather cut our losses and think about available options. It is important to be kind and compassionate and provide all the objective information to people who need to make that decision, because we are providing information about the risk here, but people themselves need to make these decisions. When developing a return to work plan, we have to consider a graduated return when feasible, starting with reduced hours or modified duties, and we have to specify clearly what restriction that they need to avoid, and that has to be communicated to the worker as well as their supervisors so that they understand what we are trying to achieve. And in the multidisciplinary approach, occupational physicians or doctors, dermatologists, general practitioner, insurer, workplace employer, so we all need to be on the same page on how to manage to get the best outcome. Ongoing review might be important, and that could be done by the general practitioner or in some cases, occupational physician to gauge on the effectiveness of the gradual return to work. After return to work, I want to cover briefly about workers' compensation. In Australia, occupational contact dermatitis is a compensable condition when the employment is a significant contributing factor. For ICD, we need to demonstrate that the workplace exposure were the predominant cause or a significant contributor. For ACD, patch testing confirming sensitization to a workplace allergen is powerful evidence. If a worker with ACD cannot return to their pre-injury role and require retraining, this should be supported through rehabilitation and return to work provisions and the relevant state or territory workers' compensation legislative system. Before I sign off, one final area I want to cover is pre-employment. During the pre-employment assessment, we should identify workers with pre-existing atopic dermatitis or significant atopy who are entering high-risk roles such as wet work or chromium-exposed work. This doesn't mean excluding them, otherwise that would raise discrimination concerns, but it means counseling them about elevated risk and ensuring enhanced skin protection from day one. At the same time, for the health surveillance program or health monitoring programs for workers in the high-risk industry should include regular skin check, questionnaires about skin symptom, and early referral pathway. It's amazing how many painters or plumbers or people who work with the allergic content do not know about the risks of contact dermatitis from chemicals they are handling. So when you are speaking to them, it is an opportunity to educate and inform them how to look after themselves, because early detection and intervention dramatically improve prognosis, and the longer the occupational dermatitis is left untreated and the worker continue exposure, the worse is the long-term outcome. Well, that's all for today's episode. This is probably the longest recording I had done. If I have to wrap up, ICD is common. It is about 80%, and it is dose dependent. ACT, on the other hand, carries worse prognosis, and sensitization is permanent. Wet work is usually the main cause of irritant contact dermatitis. For allergic contact dermatitis, PPD, epoxy resins, chromium, and rubber chemicals. Temporal improvement away from work is the strongest clinical clue for occupational causation. Patch testing is a gold standard for ACD, but negative patch test does not mean that it is not the diagnosis. Follow the hierarchical controls. Gloves are not the first answer, and they could well be the problem. Fitness to work assessment is never binary. It needs to consider within the framework of in the best interest of the worker. Early detection and intervention is the single biggest factor in the long-term prognosis. Thank you for joining me today in the Occupational Medicine Pearls podcast. If you found this episode useful, please share it with a colleague, and please add comment or email to me if I haven't covered an area that you think is important or anything you want to add to the discussion. And I will see you in the next episode. Until next time.